Hello and welcome to the ASCO Daily News Podcast. I'm your host, Dr. Monty Pal. I'm a medical oncologist, professor and vice chair of academic affairs at City of Hope in Los Angeles. Now, I'm really delighted today to be joined by Dr. Chien, a professor of clinical medicine and medical director of breast oncology at the Helen Diller Family Comprehensive Cancer Center at the University of California, San Francisco. Dr. Chien's also the chair of the 2026 ASCO Annual Meeting Scientific Program. This is a big role. I'm sure it's quite time-consuming, and you put a ton of effort into this. And Joe's actually here to tell us about the key abstracts, hot topics, novel approaches that are going to be presented at ASCO 2026. By the way, you can find our full disclosures in the transcript of this episode. Dr. Chien, thank you so much for coming on the podcast today.
Thanks, Dr. Powell. I'm really excited to be here.
Oh, excellent. I'm going to go by first names from here on out, if that's okay. We'll make this nice and friendly. This year's meeting has the presidential theme established by Dr. Eric Small, who's also at UCSF, of the science and practice of translation, improving cancer outcomes worldwide. Now, I've actually talked to Eric about this theme, and it really reflects his emphasis on the fact that we really need to be focusing on translating scientific advances and novel approaches really around the world beyond just the U.S. And as always, I think at this meeting, there's going to be tons of really terrific practice-changing abstracts. We're going to be covering some of the abstracts that really Dr. Chien felt were the highlights of this year's meeting. But before we dive into it, Joe, can you tell us what you're most excited about this year?
Yeah, there's so many things to be excited about. It's been incredible experience seeing it all come together. There are thousands of oncology professionals from over 160 countries that will be attending ASCO this year. And there were a record-breaking 8,700 abstracts submitted to the scientific program this year. And of those, we selected thousands for oral abstract sessions, rapid oral abstract sessions, and poster sessions. There will be many practice-changing and practice-influencing studies. It's hard to pick out what I'm most excited about, but of course, the plenary session will feature the abstracts that we feel are the most clinically impactful and practice-changing, and this year we'll focus on lung, GU, GI sarcoma, and heme malignancies. I also want to highlight every year there are 3 special clinical science symposium, and these are different than the clinical science symposia within the tracks. So these special CSSs, as we call them, they're focused on one theme and are meant to be cross-cutting across different disease tracks. So this year we have 3, and the first is around the clinical utility of ctDNA from early detection to treatment decisions, really going beyond just prognosis and how to really use ctDNA in the clinic. The second one is around clinical trials focused on patient-centered and patient-reported outcomes. And the third is focused on studies using AI for more personalized and accessible care.
I mean, these are hot topics. I can't imagine meeting these days without an AI-based theme.
Yeah, it's just changing so rapidly. And I think it's so important to keep up with rapid pace of change that we're seeing in the technology. So really, really exciting work. The education program also, I want to just put a plug in for that. There are over 100 sessions in the education program, and the education committee is so thoughtful about choosing topics and speakers that they think will provide the most practical and clinically relevant information in a variety of cancer settings. And as you know, as you said, Dr. Small's presidential theme this year is translating science research globally. So we have really charged the speakers to address how their research and their topic applies to resource-limited settings across the entire program, both education and science.
So, Joe, it's interesting. I was looking at your history and my history and comparing notes. You've an amazing pedigree, undergrad at Stanford, medical school at Harvard, residency at MGH, and then fellowship at UCSF. We graduated from fellowship at the same time. So, we've seen these major evolutions in oncology since, I guess it was 2009, right, that we started on faculty. So it's been incredible to see many of the sea changes. Today, we're actually going to start by addressing what is kind of an evergreen question in the field. I mean, I can't think of a single patient encounter where someone hasn't asked me, Doc, and this is beyond the chemotherapy, beyond the immunotherapy, what should I be doing in terms of diet and lifestyle? And you've picked a couple of abstracts for us to discuss today that really do hit on this subject. So maybe you could start out by telling me about Abstract 511, which is a study looking at Mediterranean diets in patients with breast cancer.
Yeah, I totally agree. It's been really exciting to see phase 3 lifestyle intervention studies being done and being successful. We saw this last year at ASCO with the challenge study, which was a phase 3 study showing that the intervention of structured exercise improves survival in patients with colorectal cancer. And I'll just put in another plug for this study. They're actually presenting a cost utility analysis from the challenge study at ASCO this year. So keep an eye out for that. But this study that you mentioned is another phase 3 trial conducted in Italy, where they randomized approximately 500 patients with early stage breast cancer to one of two treatment interventions. The first was the control arm, which was receiving standard advice on eating a Mediterranean diet and avoiding sedentary behavior. The intervention arm received high intensity advice on adhering to a low glycemic Mediterranean diet, as well as 30 minutes of daily brisk walking. And I think everybody also took vitamin D. The primary endpoint was breast cancer recurrence, and they also looked at and reported other cardiometabolic risk factor endpoints. These patients were postmenopausal, stage 1 and 2. And what they showed was, while there was no difference in the breast cancer recurrence between the two arms, they did show that those who were more adherent to the intervention arm had a lower risk of recurrence. They also showed that the intervention arm did result in more weight loss and less metabolic syndrome. So I think this is really interesting because while it doesn't support any specific intervention, it supports that lifestyle modification can lead to improved cancer outcomes. And this may be mediated through weight loss and through the metabolic factors. So I just really think as a field, we're really making strides here. So really exciting work.
And let me ask you, Joe, so you get back to clinic on Monday or Tuesday after ASCO. What is your recommendation on the basis of this trial? Because, it's interesting. There was improvement in recurrence risk, but maybe in the subset that was strongly adherent. Is this Mediterranean diet or, exercise regime something that you might prescribe to patients right away?
Well, I don't know that we know exactly what diet, because, in these two arms, well, they actually both were recommended to have a Mediterranean diet. It's just that one also had brisk walking and one was more low glycemic diet. So I think it's hard to know exactly what to prescribe, so to say, in terms of the diet. But I think what I continue to emphasize is the importance of exercise, the association we are seeing across studies with weight loss associated with improved outcomes, exercise associated with improved outcomes. So I do counsel my patients to insert these lifestyle modifications, but which exact diet and what exact exercise program, I think this study doesn't necessarily answer, but I think it's consistent with other findings across studies.
Yeah, and I'd hazard to guess it can't be a bad thing, right, for patients to undertake, a healthier diet, moderate exercise when we think about other outcomes, right?
Absolutely.
Yeah, and that sort of lends itself to the next study that I wanted to discuss with you, which is abstract 12010, also known as the Be Wells trial. This is actually led by some of the heavyweights in the field of quality of life and these types of exercise interventions, namely Jennifer Ligabelt and Dana-Farber. This was an alliance clinical trial randomizing patients with stage 2 or 3 breast cancer to a 24-month lifestyle-based weight loss intervention or health education alone. So tell us a little bit about what this study identified.
Yeah, and this study was also slightly different because they included breast cancer patients who had a BMI of 27 or higher. So really selecting patients who were overweight or obese. And as you said, a 24-month weight loss intervention with health education versus health education alone. And so this study, also a randomized phase 3 study, the primary outcome was invasive disease-free survival. At this meeting, they are not reporting out on the invasive disease-free survival primary endpoint, but will be reporting out on patient-reported outcomes and symptoms, which were their secondary endpoints. And what they show is that at 6 months after intervention, the weight loss intervention plus health education arm resulted in better physical functioning, global physical and mental health, improved fatigue than just health education alone. What we want to see is whether the weight loss arm actually lost more weight. That I don't think is being reported out here. But I think we're seeing that exercise, weight loss, this can improve patient functioning and quality of life, which goes along with the other advantages of potentially improved cancer outcomes.
Yeah, indeed. And tell us about that. Is there going to be a look at cancer-related outcomes at some point in this trial?
Yes, so that's their primary endpoint.
Got it. Yeah, that's very interesting. So I'm really keen on seeing whether or not that certainly improves in line with challenge and perhaps the previous study that we looked at. I certainly think that would be of interest. Alongside dietary interventions, alongside exercise, the one thing I can't seem to get away from in clinic are questions around some of these new pharmacologic interventions. So, oftentimes we encourage diet and exercise routines really for the benefit of weight loss. But now we have GLP-1s, right? And GLP-1s are quite pervasive. We have a lot of patients who are taking them, usually, hopefully, with our knowledge. There's this really interesting abstract 3143, that looks at GLP-1s in the context of cancer-related progression. Can you tell us about that?
Yeah, I agree. We've all heard about these agonists, which were first developed to treat diabetes. And I think the first one was approved in 2005. And since then, these GLP-1 agonists have really evolved for weight loss and now improvement in cardiovascular risk in high-risk patients. So, of course, I think the natural next question is whether GLP-1 agonists have any anti-tumor effect and whether they can improve cancer outcomes. Me too. I think I get asked by my patients at least once or twice a day or week at least about whether they should be on GLP-1 agonists to help prevent recurrence. So seeing a number of abstracts submitted this year around GLP-1. This one that you mentioned is a study conducted by the TriNetX Global Health Research Network. This is, I think, one of the largest ones I've seen so far. And it identified over 10,000 patients with stage 1 to 3 cancer across a number of cancer types. And these patients initiated a GLP-1 receptor agonist after their diagnosis. And these patients were propensity matched 1-to-1 to controls. And this included breast, prostate, lung, HCC, RCC, pancreatic cancer. And they were matched across a number of factors that you would expect, such as BMI, smoking, comorbidities, glycemic control. And what they found was that those who were on a GLP-1 agonist had a statistically significant lower rate of progression to metastatic disease. And this was specific to 4 tumor types: breast, lung, colon, and HCC. And what was really interesting, I thought, was that the authors used TCGA data and found that the GLP-1 receptor expression correlated with overall survival, particularly in breast cancer. So while this is a retrospective study and there's limitations inherent to that with confounders, I think it's really interesting. It's a large study and just provides some rationale and support for doing a prospective randomized study with cancer outcomes as the primary endpoint. I think that there would be a lot of interest in that.
I really encourage the audience to go check out this poster. It's going to be in one of the sessions of the meeting, and really take a look at the table. I'm sure they'll have it adapted on the poster that describes the hazard ratios for outcome here. I mean, these hazard ratios are impressive. If you're taking GLP-1s, that reduction in risk of progression has a hazard ratio of 0.5 in lung cancer, 0.57 in breast. And it's also quite notable that there are several cancers where there's not benefit. So for instance, I focus on renal cell. There, the hazard ratio for whatever reason is 0.95. There must be some biologic underpinnings of this. We always talk about, for instance, the obesity paradox in renal cell, where obesity is linked to the incidence of the disease, but for whatever reason is also linked to favorable outcomes with respect to therapy. This is really fascinating. On the same theme of pharmacologic interventions and so forth, we're going to talk about something that our patients shouldn't be doing, obviously, and no one should be doing, which is smoking. We all are well aware of the risks associated with it. But one of the vexing issues that we have in clinic is just how we characterize smoking, right? I think since the days that you and I were medical students, we've been encouraged to characterize the essentially tobacco pack years, right? So if somebody smoked 2 packs a day for 30 years, that's 60 pack years. But I guess there's challenges in doing this on a routine basis. This is something oftentimes we're having our clinic staff do, and on a busy day, it may miscapture. The abstract that you picked out here, I think, is a really cool one because it talks about maybe simplifying that metric and just looking at tobacco smoking duration. Can you tell us a little bit about this?
Yeah, I agree. I really like this study because I think it has the potential to change the way we decide who to screen for lung cancer. So the authors of this study hypothesized that tobacco smoking duration, so just the number of years one is smoking as opposed to the tobacco pack year criteria that we currently use, they hypothesized that tobacco smoking duration is a simpler and more clinically reliable metric to identify high-risk patients to screen. So this study compared 5-year lung cancer incidence using the current tobacco pack year criteria that per the U.S. Preventive Service Task Force, and compared it with tobacco smoking duration of greater than or equal to 20 years. And this was a retrospective cohort study in nearly 1 million vets aged 50 to 80. And that the proportion of missed lung cancer diagnoses was higher using the tobacco pack year criteria than the total smoking duration criteria. Also, using total smoking duration expanded the screening cohort, especially for women and Black individuals. Approximately 20% of total smoking duration cohort did not meet criteria for screening based on current total pack year criteria. So the authors conclude that total smoking duration performed at least as well as total pack year in predicting lung cancer risk, but it also expanded the screening population, particularly in underrepresented groups, and there were fewer missed cancers. So really interesting work.
I've got to agree because you think about your clinic workflow, and I remember doing these interviews as a medical student when you have that patient who might have smoked for 30 years but had periods on and off tobacco use. How does that factor into the equation? So I can really see how something as simple as this, just distilling to tobacco smoking duration, can be really impactful in getting us good, accurate data and getting the right people to screening. We've talked a lot about lifestyle modifications, risk factors, et cetera. There's a ton of abstracts that really deal with therapy and personalized novel treatments for various cancers. Yeah, I wanted to pick out an abstract that you wanted to highlight here, which looks at a really unique method of characterizing appropriate radiation dosing in patients with oropharyngeal cancer. So this is being presented by Nancy Lee from Sloan Kettering. It's abstract 103, and it utilizes this modality called F-meso-PET, which really allows for functional imaging of hypoxia. Can you tell us how this was applied in this study?
I love this study for many reasons. It's completely NIH funded and it's 100% patient centered. So it's actually a combined analysis of 3 phase 2 trials, and all of these trials had similar design using this novel molecular imaging tool called the fluoromeso-nidazole PET. And this PET identifies intratumoral hypoxia. So those tumors who were identified as having hypoxia, they received the standard 70 gray radiotherapy dose, whereas those tumors without hypoxia received a lower 30 gray dose. And at this meeting, they're reporting long-term 5-year outcomes. They previously reported shorter 2-year outcomes, I think, from one of the studies, but this is a larger cohort, 5-year outcomes. And what they found was that there's no difference in overall survival. In addition, there was no difference in 5-year local failure rates, no difference in regional failure, and similar PFS. I think this is such an important study to figure out how we can personalize treatment for patients based on risk, and using this novel functional imaging tool. They will be reporting out on toxicities and PROs at the meeting as well. There's a phase 3 trial to validate this approach, and I think if positive, can really establish a precision-based paradigm to spare patients unnecessary toxicity.
You know, I had to sort of start thinking about the disease that I focus on, renal cell here, right? Because it's really a hypoxia-driven disease, and it just got me thinking about whether or not this F-meso-PET modality, I've got to look into this, might potentially help us guide therapy there too. And now increasingly we're talking about radiation for the disease. So well done. Really good choice.
Yeah. And I think, I want to call out, I don't know if I said this is specific to HPV-associated oropharyngeal cancer. As you say, I think this model of stratifying patients based on risk and potentially reducing treatment for those that may do okay with less toxicity is so important in our field.
Indeed. And, ASCO is just really a bastion for phase 3 clinical trials, practice changing data. And one that is actually in the oral abstract session is abstract 11500 being presented by Andrew Wagner from the Dana-Farber. And this looks at gastrointestinal stromal tumors, or GISTs. And this study evaluates bezuclastinib with sunitinib versus sunitinib monotherapy. Tell us a little bit about this one, Joe.
Yeah, the treatment of GIST tumors has become more targeted and individualized over the last couple decades. And I am not a GIST expert. I'm a breast oncologist. But my understanding is majority of GIST have activating KIT mutations. And since imatinib, there's been a number of additional TKIs and targeted therapies approved. In general, the paradigm has been single agent targeted therapy, one after another. And imatinib first line, sunitinib is second line. And this study, which is the phase 3 PEAK study, will be presenting data around combination therapy. And so this trial randomized over 400 patients to bezuclastinib, which is a potent selected KIT tyrosine kinase inhibitor, which is better for exon 17, 18 mutations, whereas sunitinib, I think, is better for exon 13, 14. So they're randomizing patients to the combination of bezuclastinib and sunitinib versus sunitinib alone. And they found impressive improvement in PFS with the combination of 16 and a half months versus 9.2 with sunitinib alone. So that's a hazard ratio of 0.5, so 50% improvement, which is really great to see. The overall response rate was also significantly higher, but of course, the overall survival remains immature. These are highly anticipated results in a field that has historically been using single agent therapies.
Indeed. I mean, I still remember some of the initial data coming out for GIST, with targeted therapies, imatinib, et cetera, and just being so blown away. And it's very, very promising, and I think heartening to see that the field continues to advance. I'm sure there are patients who progress beyond those standard therapies and need other options.
And I think it's also, asking, this approach of targeting one mutation at a time as they emerge versus the strategy of combining therapies and treating multiple resistance mutations at the same time. And of course, like all combination studies, toxicity is going to be really important to assess. However, based on what they have put in their abstract, it looks like the combination was very well tolerated with low discontinuation rates.
Well, Joe, thank you so much. I mean, this has been an amazing primer on multiple very interesting abstracts that are going to be presented at ASCO 2026. I really want to thank you for all your hard work in building such a robust program this year. Our listeners can access links to the studies we discussed today in the transcript of this episode.
Thank you so much. Thanks for having me.
Oh, you got it. And to our listeners joining us today, be sure to catch up on my top takeaways from ASCO 26. These are going to be short episodes that will drop each day of the meeting. So subscribe to the ASCO Daily News podcast wherever you prefer to listen, and join me for concise analyses of the meeting's key abstracts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.